Good morning, everyone. Welcome to today's COVID-19 Community of Practice for Ontario Family Physicians. My name is Dr. Ali Damji, and I will be your moderator for today. I'm a family physician from the Credit Valley Family Health Team and Division Head of Primary Care at Trillium Health Partners in Mississauga. The Department of Family Medicine at the University of Toronto and the Ontario College of Family Physicians are pleased to continue to be offering these sessions. And we're pleased that today's session is on managing respiratory illness in kids and COPD, a COPD-COP, if you will. I'm going to turn things over to Dr. Jobin Verghese, the OCFP President-elect, to launch today's session.
Thanks so much, Ali. When we go to the next slide, we'll see the land acknowledgement on the next slide. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and the DFCM recognize that the many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respects the Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. And I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And as we honor these lands, it's important to remember these lands have sustained life for generations of Indigenous people. And so this acknowledgement has to go beyond words and bring us into action and reflection and education, especially with Truth and Reconciliation Day approaching on September 30th. This day is going to be an important opportunity for all of us, especially as healthcare providers, to deepen our own understandings on the truth and on our shared understanding and shared history with the Indigenous people within Canada. And it's a day to reflect on the calls of action set forth by the Truth and Reconciliation Commission, especially with those that intersect with our roles as healthcare providers. The history of colonization and impacts of Indigenous health are undeniable, and we need to continue to recognize and address the disparities in health outcomes that affect Indigenous communities. This will also acknowledge the unique challenges that the Indigenous communities face with regards to higher rates of respiratory diseases like asthma and tuberculosis, to a broader issue for systemic inequity. And so we hope that the conversation will continue to occur and that we move towards action. And with that, I'll hand it back to Ali, and I welcome you to today's section.
Great. Thank you so much. And welcome to you as well, Jobin, to your new role and to the COP today. Thank you for being here. Just to remind our participants, these sessions are Mainpro accredited, and I'd like to also take this opportunity to recognize the Scientific Planning Committee that puts together the sessions. Next slide, please. This will be the order of the presenters for today, and I'm going to be turning it over shortly for them to introduce themselves. Next slide, please. First, we'll start with Dr. Grossman.
Good morning, everyone. My name is Ron Grossman. I'm a professor of medicine at the University of Toronto. I'm a respirologist by training, but I have a major interest actually in respiratory tract infections, and prevention of respiratory tract infections. I have relationships with virtually every company that makes an inhaler. The good news is I deal with everybody relatively equally. I am on nobody's payroll. I own no stock in any company. My kids own no stock in any pharmaceutical company. So I think I'm reasonably balanced. And my intention is to try and cover some new aspects of the management of COPD in adults. So we're going to do adults first, kids later.
Great. Thank you so much. Thank you for being here. Over to you, Dr. Stoltz.
Hi, everyone. I'm Tasha Stoltz. I'm a general pediatrician. I practice in the Kitchener-Waterloo area. I work at Grand River Hospital and also have an outpatient consulting practice. I have no conflicts to declare other than I teach at McMaster.
Great. Thank you so much. I will move to the next slide. Over to you, Dr. Verghese.
Thanks so much. And as Ali mentioned, I'm the president-elect for the Ontario College of Family Physicians. I also have a role within Toronto Metropolitan University School of Medicine as the interim assistant dean of primary care education, and within William Osler Health System as the associate vice president of academics. Thanks.
Thank you. As for myself, I do receive an honoraria for being the moderator of the COP, which of course does not pose a conflict of interest for today. And I'll turn things over next to Dr. Warshawski, who many of you will recognize. Daniel's kindly agreed to help us with some of the Q&A in case there's some questions that are more relevant for him. So I'll turn things over to him to introduce himself again.
Yep. Thanks, Ellie. Hi, everybody. Daniel Warshawski. I'm one of the Associate Chief Medical Officers of Health in the province and still nothing to declare. Thanks for having me.
Thank you. All right, next slide. So just a reminder for our participants in terms of how to participate in today's session. So all questions should be asked using the Q&A function, and I already see many of you have already started putting questions, which is great. Before you submit a question, always take a look at the list, and if you see a question that's the same as what you were going to ask, feel free to just upvote that particular question, and it will come up to the top, and the ones that are the most upvoted will be the ones that I will ask. As for the chat, make sure to use the chat for networking purposes only. Don't put questions into the chat because I won't see them. Next slide. So the order of the presenters will be starting with Dr. Grossman talking about COPD in adults. So we'll go to the next slide and I will turn things over to you.
I guess I'm on first. So I'm going to be talking about exacerbations of COPD particularly, and especially prevention of exacerbations of COPD. And the reason we think that this is a very important subject is, first of all, it has the biggest impact on our patient population. Second of all, it has the biggest impact on healthcare utilization. So if we can minimize some of these exacerbations with better drug therapy and preventive measures, everybody is going to win. So the particular concern we have about exacerbations in COPD is that exacerbations are associated with hospitalizations and ultimately with mortality. So what you're looking at here is the probability of survival over 5 years, stratified by the likelihood of having exacerbations. So on the top, the dark line represents individuals with COPD followed for 5 years with no exacerbations. And at the end of 5 years, 80% of them are still alive, but 20% of them are dead. The dashed line in the middle represents individuals who are averaging 1 to 2 exacerbations per year. And if you follow them out for 5 years, half of them are dead at the end of 5 years. And when you look at individuals who are frequent flyers, frequent exacerbations, 3 or more exacerbations per year, again, at the end of 5 years, 80% of them are dead. So exacerbations in more severe COPD is clearly a mortality signal. So one of the goals of therapy is to prevent these episodes, hopefully to reduce hospitalizations and ultimately reduce mortality. Next, please. The other thing that we know is once you get an exacerbation associated with a hospitalization, the time interval between these flares becomes shorter and shorter. These are data that come from an epidemiologist in Montreal and clearly shows that the time interval between the first and second exacerbation is about a year and a half. But subsequently, the intervals become shorter and shorter. So it's like a vicious downhill spiraling course that occurs once these individuals start getting these exacerbations. So if you can have the next slide, please. If I can summarize this, preventing and treating exacerbations really is a top priority for management of COPD to reduce the risk of hospitalization and bad outcomes. And the best predictor of future exacerbations is a history of exacerbations. So the questions you need to be asking patients are things like, since the last time I saw you, has anybody seen you for a flare of your COPD? Did someone give you antibiotics? Did someone give you steroids to control your symptoms? Those are the episodes that we're trying to prevent. Next slide, please. The rationale behind the bad outcomes in these individuals when they get hospitalized is not necessarily related to their lung disease per se. That is, not many of them really die of overwhelming exacerbation of COPD associated with respiratory failure, ending up in the ICU on a ventilator. That's not the course. What really happens to these individuals is once they get hospitalized, they are really likely to experience a cardiovascular event. Myocardial infarction, heart failure, atrial fibrillation. These are very common phenomena in individuals who get an exacerbation, get hospitalized. This is the risk of having one of these cardiovascular events after one of these exacerbations. And you'll note that the risk of having a cardiovascular event is more than tripled in the first 2 weeks following one of these events. And the risk persists for at least a year. Now, the greatest trigger for exacerbation of COPD are viral infections. So viruses account for about 60% of these flares. Bacteria account for about 20%, and maybe 20% are related to, I'm still smoking, I didn't take my drugs, et cetera, et cetera. But viral infections and bacterial infections are the major triggers. And we know that bacterial and viral infections are associated with an acute inflammatory event, which can lead to cardiovascular complications, as I'll show in just a minute. But the notion is, someone gets an exacerbation, they get hospitalized, their mortality risk is clearly elevated, and the mechanism of that is a cardiovascular event likely. Next, please. So here's the mechanism of all of this. All of these events, whether triggered by viruses or bacteria, are associated with a profound inflammatory response. And what inflammation does is it can disrupt plaque, coronary artery plaque. So what's being visualized in this slide is a coronary artery or any vessel with a plaque, which is the object shown in yellow. And what the inflammation does is it will rupture the fibrous cap on top of that plaque. The second thing the inflammation does is it will activate platelets. So platelets become very active once they're in a setting of inflammation. And when platelets are activated, what they do is they stick to abnormal surfaces. So the abnormal surface is the ruptured fibrous cap on top of this plaque. So now you have a nidus of platelets sticking on top of this abnormal surface. And once you get a platelet plug, that's the surface upon which you then get a fibrous, a blood clot. So the mechanism of this myocardial infarction, heart failure, et cetera, is related to acute inflammation associated with this exacerbation in someone who has underlying coronary artery disease, which the vast majority of COPD patients will have because they're elderly, smokers, often male. The fact of the matter is it's a cardiovascular event that will do them in. Can I have the next slide, please? The other thing that's important to note is that when individuals are treated for an exacerbation of COPD, particularly when they're hospitalized, the standard of care is an antibiotic to try and deal with any bacterial cause of their exacerbation, and usually a course of oral corticosteroids. And the usual standard is 50 milligrams for 5 days. So do we have a concern about the steroids? And the answer is, you bet we do. So there's a evolving idea or notion limiting the total exposure to steroids in someone's lifetime is really important. And the magic number turns out to be 2 grams. So how do you get to 2 grams in your lifetime? Well, if you get 50 milligrams for 5 days for a course of treatment of an exacerbation of COPD, that's 250 milligrams. 2 episodes in a year, you're at 0.5 gram. 4 years in a row, you're at 2 grams. So what's special about 2 grams? Well, I'm showing you one slide of many that I could show you, detailing the dose relationship between the cumulative dose of oral prednisone and side effects. So you see, for example, all-cause mortality is related to higher uses of prednisone. Now, this almost certainly is a marker of more severe disease. More severe disease gets more prednisone, so you're going to die. But in fact, more steroids can actually kill you because more steroids are associated with respiratory infections, particularly pneumonia. And of course, pneumonia could kill you. But you also see a dose response for osteoporosis with and without fractures. There's a dose response for, as I pointed out before, there's a dose response for type 2 diabetes. I'm not showing you some of the others, but congestive heart failure. There is a dose response for weight gain. There's many of these cataracts and on and on and on. So at the end of the day, exacerbations are associated with cardiovascular events, and the treatment of these exacerbations are associated with a cumulative side effect profile, which is clearly undesirable. So at the end of the day, you really want to avoid these exacerbations as best you can. Next, please. So how are we going to do that? And very recently, in the fall of last year, the Canadian Thoracic Society published their long-awaited revised guideline for the management of for COPD management, and particularly focusing on exacerbation prevention. So this is the only guideline that we have that is truly evidence-based. Many of you will be familiar with the GOLD recommendations. The GOLD recommendations are a group of individuals like me sitting around a nice table in a very good restaurant, drinking very good wine, and coming up with some suggestions, but it is not evidence-based. In contrast, the COPD guideline was evidence-based. Excuse me. So I want to make essentially 2 points here. First, the standard of management for COPD today is dual bronchodilator therapy. A single bronchodilator therapy with an antimuscarinic or a long-acting beta agonist really is only recommended for the people with a very, very, very mild disease. But the core of management is a combination of a long-acting beta agonist and a long-acting muscarinic antagonist. These individuals should not have a history of a COPD exacerbation. Remember, from the beginning, I said the greatest predictor of COPD exacerbations is a history of COPD exacerbations. So in the absence of that, dual bronchodilator therapy is the core of treatment. In contrast, though, in individuals who have a history of exacerbations, the right answer is triple therapy, a long-acting muscarinic antagonist, a long-acting beta agonist, and an inhaled corticosteroid. So who are these people at high risk? The people who have a history of exacerbations. That's the current recommendation. Now, individuals who continue to be symptomatic, despite this triple therapy, there's some additional things that we can offer. Antibiotics given on a prophylactic basis, PD4 inhibitors, but these are often offered by specialists, primary care physicians. If they really need this, they probably should be seen by a consultant. Next, please. So what's the evidence to support this recommendation? There are 2 very large randomized clinical trials. I'll show you only one because it's the best of the 2. This looked at a triple therapy. It was fluticasone, umeclidinium, and vilantrol in a single inhaler. And the primary outcome in this very large 1-year randomized controlled trial involving thousands of patients was exacerbation rate. And what they demonstrated was that triple therapy, the 2 bronchodilators and inhaled corticosteroid, was associated with about a 25% risk reduction of exacerbations compared to dual bronchodilator therapy in the population at risk, that is, given a history of exacerbations. So this is a stratified analysis. So the primary outcome was the one I just talked about, exacerbations. But the second outcome afterwards, once they achieved the primary outcome, was to look at hospitalizations. And indeed, triple therapy was associated with about a 30+% reduction in hospitalizations compared to dual bronchodilator therapy. Next, please. Once they reached their second outcome, which was hospitalization, they could then, in a stratified analysis, go to the next outcome, which was mortality. And indeed, they showed that the regimens that included an inhaled corticosteroid were associated with a reduction in mortality. And the difference was significant, and the absolute difference was a little under 1% in this 1-year clinical trial. Putting things in perspective, in the cardiovascular mortality for ACE inhibitors and lipid-lowering agents, in a 5-year trials, the absolute risk reduction in mortality was in the ballpark of 1 to 2%. So this is very similar to what we see in the cardiovascular trials. Because of this study and another study sponsored by AstraZeneca, which looked at their triple therapy showing very similar results, that led to the change in the guidelines that the CTS has written. Next, please. So does it matter how you give triple therapy? Why don't you just give Advair and Spiriva, for example? So that's triple therapy. It's a lab inhaled steroid plus a standalone LAMA. The answer is it really does make a difference. Individuals who are on triple therapy in a single inhaler, which is the red area that you see on this slide, are much more likely to be adherent to therapy over the course of several years compared to those who are on triple therapy in separate inhalers. It's not a better adherence, but there's also a reduction in exacerbations when triple therapy is given in a single inhaler compared to 2 inhalers. And there's actually a mortality benefit if they're given triple therapy in a single inhaler compared to the two inhalers. Next, please. So the organizations that make recommendations for treatment have basically made similar statements. So the gold statement in this year, 2024, says that single inhaler triple therapy is more convenient and effective than multiple inhalers with improved adherence. And the CTS has also said that triple therapy in a single inhaler is favored over multiple inhalers because of adherence, reduced chance of errors, and potential benefits. So the current standard of management for individuals who have frequent exacerbations, particularly associated with hospitalization, is triple therapy, and it should be offered in a single inhaler. And I'll stop there, and thank you very much for your attention. I'll be more than happy to answer any questions.
Great. Thank you so much for that, and really appreciated the way that you really synthesized the evidence and also gave really clear recommendations on that. So thank you. So I'll start with a question here, which is from one of our attendees here around what you would give for an acute exacerbation of COPD in the office. So what doses and durations for the inhalers, the prednisone, antibiotic choices, pen versus pen allergic. I think someone's really looking for your advice if we see someone in an office.
Well, I helped write the recommendation for antibiotic management of exacerbations of COPD. So let me deal with that first. So the recommendation really depends on the severity of their underlying lung disease. So people who have mild to moderate COPD, it probably doesn't matter which antibiotic you give. You want to give a beta-lactam, you want to give a macrolide, a cephalosporin, tetracycline, they're all okay. And I don't think there's a preference one way or the other. And then you'd look at patient preferences, allergies, that sort of thing, convenience. For the individuals who have more severe COPD, so the moderate to severe COPD, they're much more likely to be infected with Haemophilus, often a beta-lactamase producing Haemophilus, and they're more likely to be infected with gram-negatives. So the two choices that we prefer in those individuals would be a combination of amoxicillin and clavulanic acid, so clavulin, or a respiratory fluoroquinolone, which would be Levaquin or the Bayer one. So the quinolones should be reserved for the more severe patients because it'll cover all of the pathogens, and the alternative would be amoxiclavin. For the milder individuals, it doesn't really matter. In terms of what else do we give for mild to moderate COPD with an exacerbation, an antibiotic should be enough. We would reserve the prednisone for people who have more advanced disease. The evidence is that prednisone will either shorten a hospital stay, in some instances may prevent someone going to the hospital with their exacerbation. That being said, as I try to point out, we're not crazy about giving prednisone, so if we can avoid it, we would like to do that.
Thanks so much. And then from an inhaler standpoint, do you have specific recommendations for the inhalers that we should use in this situation?
So the individuals who are on triple therapy already, the only other inhaler you might want to use is a short-acting beta agonist for some additional relief. There's no value in giving additional antimuscarinic because you're already on the antimuscarinic, and more is not any better than less. But you can give additional doses of a short-acting bronchodilator. It's quite safe, and we don't really anticipate any problem. And when people come into the emerge, we basically pour these medications down their airway anyways. So the doses you're going to give as an outpatient is trivial compared to what they're given in emerge very safely.
Great. Thank you so much for that. And in doing that, you also answered one of the other questions about, for milder COPD exacerbations, do we need to give the steroids? And it sounds like the answer to that is no. So
no.
Thank you for that. So another question here is on the use of beta blockers in COPD. So one of our attendees here mentions that they've read some systematic reviews that said there maybe is some benefit and not as harmful as we initially thought. But that being said, other studies seem to point to not much of a benefit. So what are your thoughts on that, beta blockers in COPD?
There are 2 points. Number one, it does nothing for the disease. Number two, the selective beta blockers are safe. So if you need to use a beta blocker for heart rate control, blood pressure control, whatever, they're perfectly okay in COPD patients, but there's, I think, the evidence to support them being a specific benefit for the COPD patients is absent.
Thanks. Another question here is about the inhaled corticosteroids and pneumonia risk. I recall there being some talk about that, and initially there were recommendations against it. Has that changed?
Yes and no. So first of all, there is a risk. The risk is quite low, but it's clear, it's real, and it's one of the reasons we like to avoid steroids altogether if we could. The fact of the matter, though, is the benefit you get from the inhaled steroid in the right patient, that is, that individuals having frequent exacerbations, seems to weigh quite substantially the risk of developing pneumonia. So it's a risk, and the evidence would suggest that the benefits in the high-risk patient, that is the one having frequent exacerbations, far outweighs the risk of having pneumonia. But does pneumonia occur with inhaled steroids? The answer is yes. There does not appear to be one inhaled steroid better than another in terms of risk of pneumonia. They all are associated with that risk. In a similar fashion, you may hear that budesonide may be less risky than one of the fluticasone, but in the best randomized controlled trials, which is one of the ones I just showed you, and the AstraZeneca-sponsored trial, budesonide and fluticasone were both associated with pneumonia, and the risk was identical in a similar patient population. So they're all associated with it, but the risk is much lower than the benefit you get from reducing the risk of exacerbations and hospitalizations and ultimately death. By the way, the real treatment to prevent exacerbations is the best inhaled therapy, which I just described, but also every one of these patients should be vaccinated with any vaccine that prevents a respiratory infection. I mean, it's a combination of maximum vaccination policy plus the best drug therapy will give us the best results.
And maybe just for our audience as well, too, would you be able to just remind us of what you would recommend from a vaccine standpoint for patients with COPD?
All of them.
Oh, everything. So
all of them. So
yeah.
COVID, influenza, RSV, pneumonia, even shingles. Shingrix has been shown. Well, first of all, shingles is much more likely in a COPD population. They're a high-risk population, but when they get shingles, they get into trouble. If you get thoracic shingles and you got bad obstructive lung disease, trust me, it's going to affect their breathing. So all of these vaccines we think are really important in the COPD population. They are amongst the highest risk of getting into trouble from these infections compared to any other group. Their risk of having bad outcomes, for example, for RSV or influenza, is similar to the immunocompromised. So they're a high-risk group, need to be vaccinated.
Definitely. Thank you for that. So we have another question here about the triple inhaler therapies that you described. Could you comment on how you choose which triple inhaler that you would use in a situation, or are they all kind of similar in terms of their effectiveness?
So they're not similar, they're different. And I don't want to get into the nitty-gritty, but a lot of the outcomes associated with these medications has to do with adherence. So the fundamental principle for chronic disease management, I mean, I shouldn't be telling primary care physicians how to do chronic disease management. That's your life. You're looking after everybody with all these chronic diseases. I think the fundamental principle of chronic disease management is simplicity. You want to make it as simple as you can, which makes it more likely than not that the patient will actually take the drug. So I think a medication, for example, taken once a day is going to be better than any medication taken more than once a day. They're just more likely to take it. There is another difference amongst these triples. The components of the triples are quite different. So again, without being too critical one or the other, one of the triples has components that are 40 years old. I mean, literally all the drugs are more than 40 years old. And the other one, the drugs are newer, more potent, almost certainly better. So there's no head-to-head trials. You can't say one is better than the other, but on the face of it, I think taking a medication once a day is going to be preferable to something more than once a day. But then some patients would prefer a meter dose inhaler, which one triple is offered in a meter dose inhaler, and other patients really like the dry powder inhaler, which is the other one. So you have some choices in terms of devices, but if you're looking at adherence as the outcome you're really interested in, I think one inhaler given once a day is going to be preferable.
And are there specific ones that are covered under ODB that you're aware of?
They're all covered.
Oh, they're all covered. Oh, that's great. Awesome. Okay, so next question here is around using tapering doses of steroids. Do you prefer taking a tapered approach or the standard 50 milligrams?
I don't taper. I just use the standard 5 days and I stop. Sometimes there's interesting trials going on now looking at shorter courses of prednisone than 5 days, but in a hospital setting where the marker they're looking at is the blood eosinophil count. And there's at least one trial that showed that if you give prednisone and on day 2 their eosinophils disappear, you can stop the prednisone, they'll do just as well. That's, you know, all exploratory. It's going to come out over a period of time, how we're going to manage this. But the notion of having to taper prednisone, I think we just don't do that anymore. The short courses seem to be quite safe.
Great,
There's
thanks.
also nothing magical, by the way, of 50 milligrams. It's just easier to use. All the studies were actually done with 40 milligrams. So, but that's 8 pills of prednisone as opposed to 50, which is 1 pill, right? So it's a convenience matter more than anything that people are using 50 milligrams. The lower the dose, the better in the long run because of the side effect profile I referred to. And a lot of patients, for example, might respond to maybe 20 milligrams of prednisone, 15 milligrams of prednisone. No one's really looked at it that way. But most of the trials, the dose that was actually used was 40 milligrams.
Yeah, it's funny. It reminds me of one of my first few weeks as a resident in family practice where I prescribed the 40 milligrams for someone and they were quite unhappy with me because they had to take 8 pills. And I remember that was a teachable moment. So it just reminded me of that. The next question here is about mucolytic therapies. Do you have any suggestions for that for patients with COPD?
I've never been impressed with mucolytic therapy. The best therapy to reduce secretions is probably an antimuscarinic, because they do reduce secretions. Beyond that, there's not all that much. Another, just a kind of a heads up, for individuals who are continuing to exacerbate despite triple therapy and all the other things you might want to throw at them, there are biologics that are almost certainly going to be approved for the management of these patients. So dupilumab, an IL-4, IL-13 blocker, has been shown in a population of bad COPD patients exacerbating despite best therapy to reduce exacerbations by about 30%. And the rationale why one of these IL-4, IL-13 blockers might work, which they're obviously designed for asthma, and they work very well in asthmatics, is that the IL-13 molecule is responsible for the production of mucus. And when you block IL-13, you really do reduce mucus. So the thinking is that dupilumab, of all the agents that are out there, is probably the only one that's really going to be reducing mucus. And that's probably going to come in. It hasn't been approved yet for use in COPD, but there's 2 large randomized controlled trials that have shown a benefit, and it is under review by the FDA currently for that indication. I'm not sure about Health Canada, but certainly the FDA is going to be looking at it. So that's going to be another, you know, tool in the toolbox for those people who are having ongoing problems. But it's probably the only one I know for sure that will reduce secretions other than an antimuscarinic.
Thank you. The next question I wanted to ask you is again going back to the subject of the cumulative doses of steroids. So when we're thinking about that, are topical steroids for, let's say, skin conditions part of that as well? Do they add to that cumulative burden, or is it solely
No, it's prednisone. It's not the inhaled steroids. It's not topical steroids. It's prednisone. And this dose relationship of cumulative prednisone dose has been shown in COPD. I showed you some of the data, but it's also been dramatically shown in asthma as well. So the goals of treatment are to reduce the exposure. Part of the goals of treatment are to reduce the exposure to prednisone. And so best management with the inhaled medications that we have do that. And that's why we're trying to be aggressive about using the best inhalers, the most potent inhalers, to minimize the risk of these flares, either of asthma or COPD, and therefore the risk of exposure to prednisone.
Thanks.
I'm sure this also applies, by the way, for the rheumatologic community, for the dermatologic community, for all of those conditions where prednisone is given. But sometimes you have no choice. You have to give it. But minimizing the exposure to prednisone in the long term clearly is desirable.
Mm-hmm. And when making that decision about ICS therapy, you alluded to this earlier, but I wanted to just pick up on it again. Blood eosinophil counts, like, is that something that you use in your practice, or something that you would recommend for us to use when deciding to add ICS?
The answer is no right now. The eosinophil, and we're talking about COPD. If we're talking about asthma, it's a different story. But in COPD, the eosinophil story is clouded. What we know is if the blood eosinophil count is less than 100, so less than 1% of a CBC, inhaled steroids probably will harm you. The risk of pneumonia is likely going to outweigh the benefits you'll receive. Similarly, if the blood eosinophil count is elevated in excess of 300, particularly if it's going further north, 400, 500, that almost certainly means there's an element of asthma. Remember, asthma is a very common condition. COPD is a very common condition. So there's often overlap between the two. There is no asthma COPD overlap syndrome. That doesn't really exist. But two separate disorders in one individual clearly does exist. It's going to exist just based on the population trends that we have. So there are patients who have an element of asthma as well as their COPD, and they do respond to inhaled corticosteroids. So that individual patient, and you often have a history, there's a history of asthma, or there's a lot of allergies in that individual. They may have been diagnosed with asthma as a child and outgrew it. Now they have COPD because they smoked, but they may have an element of asthma coming back. And if there's anything, there's a hint of asthma, then you should offer them an inhaled steroid.
Great, thank you so much. So we have a few questions here actually that are on a similar theme, which is just if you could make it easy for us in terms of what we should write on a prescription, what triple therapy inhaler, the doses or durations of the antibiotics for mild and severe, would you be able to outline that for us?
Well, on the antibiotic side, it looks like 5 days of any antibiotic is more than enough. You don't have to prolong antibiotic courses 7, 10 days, 2 weeks, ridiculous. It doesn't add anything. The bacteria is dead in 24 hours. What you're really looking at is the prolonged response to reducing the inflammation associated with the infection. So 5 days of virtually any antibiotic, I'm sure, is more than enough. I really don't want to get into the specifics of recommending one triple therapy versus another. I don't think that's really the purpose of this. I think the concept of triple therapy in a single inhaler is the take-home message. And individuals look at these inhalers, look at the devices, and then make up their own decision about which one is best.
Yeah, I think that's totally fair. And then I'm gonna just ask one final question, kind of a broader system level question for you, for your vantage point as an expert here, is in terms of exacerbations of COPD or the burden of disease from COPD, have you noticed that there's been changes because of environmental changes like climate change, wildfires, air pollution, heat? Just curious what your thoughts are on that and what we might expect.
Well, the biggest impact I think we've seen in the last 10 years is COVID, where COPD exacerbations disappeared. Just went away. And nobody got, very few people got hospitalized for exacerbations of COPD, and we didn't see them in our clinical practice. And that has everything to do with isolation, masking, the usual sorts of things. So over those couple of years of COVID, COPD exacerbations went away, but gee whiz, it's back because people are behaving the way they've always behaved. COPD exacerbations are the second leading cause of hospitalization in this country after live births. So it's an important condition, and aggressive management of these patients can have an enormous impact on our healthcare system. This may make one other point about these new medications, new techniques, new vaccines. All of these interventions, I don't think particularly are cost effective in the classic sense. If you said something was cost effective, my understanding of that would be if it's so cost effective, we would close hospitals and fire nurses. Now, I don't think we're going to do that anytime soon. What these new technologies really do is they salvage the system. They protect the system. If we didn't have new technologies which gave you better and better outcomes, the end result would be as the population increases and ages, we would be completely overwhelmed. I mean, we saw that with COVID. We were completely overwhelmed. So by adopting new technologies, which clearly have better outcomes, what we're really doing is allowing our system to continue being operational. And we don't have to keep building new hospitals and adding new beds and et cetera, because we're not going to find new hospitals very quickly. We're not going to find a whole bunch of new doctors. Hiring nurses is a problem. So adopting technology, I think, is a system-saving intervention more than a cost-effective intervention. I think that's really the benefit of all of these things. It's a different way of thinking about it.
Yeah, definitely some food for thought. Thank you for that. So with that, we'll bring the slide deck back up. And I might come back to you, Dr. Grossman, if we have more questions at the end.
Sure.
But for now, I will turn things over to Dr. Stoltz.
Hi, everyone. Thanks for having me today. Can we go to the next slide, please? This is actually the third time I've presented on this topic here. So for those of you who've heard my talk before, I'll go pretty quickly, but I've also opted to focus a little bit more on infections this year as we're starting to head into viral season. So thank you to those of you who submitted questions in advance. I've hopefully included some topical discussion around RSV and COVID from your questions. Next slide. So first off, upper respiratory tract infections. As you know, these kids will present with sneezing, stuffy nose, headaches, sore throat, myalgias, possibly a low-grade fever, maybe a cough. This is always viral in cause. Your diagnosis is clinical, and these kids are overall going to be generally pretty well appearing. Nasopharyngeal swab is never necessary, especially in the outpatient setting, because it does not change management. Treatment is supportive, so antipyretics for comfort and pushing oral fluids for hydration. Really no role for any kinds of steroids, inhalers, or antibiotics. Next slide. Next on our spectrum is croup, which is an acute onset upper airway obstruction. The cause is also always viral. Classically, parainfluenza is the most common cause, although most viruses can cause it, and we do see a lot of croup secondary to COVID. The typical age group here is 6 months to 3 years. So if you're seeing someone outside of this age range, or those who have sort of recurrent, prolonged, or severe symptoms, do consider other differentials. Kids will croup will have a barky cough and stridor. Usually the stridor is only inspiratory, although you can have expiratory or biphasic stridor and varying degrees of respiratory distress in more severe croup. So if you're seeing that, send them to the ER. Symptoms usually last between 3 to 7 days. If a kid looks toxic, drooling, has dysphagia, those are worrisome signs, not in keeping with croup, should be sent to the emerge. Next slide. The diagnosis, again, is clinical. If you do a chest x-ray, it will probably be normal. If you do a lateral neck x-ray, you will see what we call a steeple sign. However, it's actually not necessary for diagnosis. Swabs are also not necessary. Treat with 1 dose of oral dexamethasone to help with the swelling in the upper airway. For most cases of mild croup that you'll be managing in your offices, this will be adequate. And again, no antibiotics are indicated. Next slide. So bronchiolitis, it's a viral lower respiratory tract infection, typically in children less than 2 years of age. Lots of different viruses cause bronchiolitis, including RSV, which accounts for about 30% of bronchiolitis, but also, influenza, COVID, rhinoentro, metapneumovirus, etc. These kids will present with fever, cough, rhinorrhea. On your exam, you'll see varying amounts of respiratory distress, and they may have either diffuse wheeze and or crackles. Other differentials to consider are other pathologies that can also present with wheeze and crackles and respiratory distress. So in particular, asthma, pneumonia, foreign body aspiration, etc. Next slide. The diagnosis for bronchiolitis is also still clinical. A chest x-ray is not required for diagnosis, although sometimes we will do this for cases of severe respiratory distress, but it's usually not necessary in the outpatient setting. Labs and an NPS, again, are not necessary in the outpatient setting either. Treatment for bronchiolitis is supportive, and there's no evidence to do anything beyond supporting hydration and breathing. This is a really tough one, especially because these kids can present really sick. Nasal suctioning can be helpful, although frequent and deep suctioning can cause more problems by further inflaming the mucosa and obstructing the airway. What I usually recommend for parents for mild bronchiolitis that's managed in an outpatient setting is to do gentle suctioning with saline drops just prior to feeds to support hydration. There's no evidence for the use of SABA, steroids, antibiotics, antivirals in the treatment of bronchiolitis. You'll see that sometimes as pediatricians in hospital, we will use salbutamol in certain patients with bronchiolitis. And the rationale is this. First presentation wheeze can also be asthma. And therefore for children with a strong personal or family history of atopy and severe respiratory distress with a wheeze, sometimes we will do a trial of salbutamol to see if it's helpful. In hospital, we have the benefit of watching them pre and post salbutamol administration, so we can determine pretty quickly whether or not they're bronchodilator responsive. Keeping in mind that especially for young infants, they have inadequate beta agonist lung receptor sites and immature bronchial smooth muscles, so you may actually not see a huge benefit from SABA. Also, in bronchiolitis, you actually have obstruction of the airways with inflammatory material rather than bronchoconstriction, so you may not see any benefit at all, and these kids just get really jittery and tachycardic. Again, it's viral, so no antibiotics, no steroids. We usually see symptoms peak on day 4 to 5, especially when RSV is the cause. So this can be really helpful in terms of predicting severity of presentation and counseling for families. Next slide, please. Children with a bacterial pneumonia will typically present with a high-grade fever, severe cough, and either generally appear sicker or have longer course of coughing and disease. They will again have variable degrees of respiratory distress. The main bacteria that causes pneumonia in kids is strep pneumo, but you can get semi-typicals in older school-age children. Your examination will still be key. You will hear focal crackles on exam and no wheeze. In these cases, you do want to do a chest x-ray to confirm the diagnosis. A bacterial pneumonia will show a focal lobar consolidation or worse, which is fairly classic and sets it apart from a viral cause. For atypical pathogens, they could classically have bilateral interstitial infiltrates, and the classic finding is that typically the chest x-ray is much worse, whereas the patient has relatively mild but persistent symptoms. A nasal pharyngeal swab and labs, again, not indicated in outpatients with uncomplicated pneumonias, as they should not change your management. Next slide. The treatment for uncomplicated community-acquired bacterial pneumonia is amoxicillin. We recommend high-dose amoxicillin to overcome the relative resistance of strep pneumo, and TID dosing is preferred over BID for the same reason. If they've recently been on amoxicillin, say for an ear infection or anything, you can use amoxiclav. We usually treat for about 5 days for uncomplicated pneumonias. Treatment for pneumonias caused by atypicals is a little bit more controversial. The reason for this is that those infections usually resolve without antibiotics, but may be helpful for those with severe infection or if there's a persistent cough. Treatments usually with macrolides, we usually use azithromycin in kids for about 5 days. We typically see improvement after 48 to 72 hours of antibiotics. Repeat chest x-ray is not necessary in kids, especially if there's clinical improvement. Next slide. I'm going to speak briefly about pertussis because there have been rising numbers in the province. It's an infection caused by Bordetella pertussis and has a pretty characteristic pattern of symptoms, as you can see here. So it has about a 5 to 10 day incubation period. Then you have this initial phase lasting about 1 to 2 weeks, where kids usually have symptoms that are essentially indistinguishable from a viral URTI. So cough, runny nose, coryzal symptoms. Despite this, they're highly infectious during this phase. The second stage, the paroxysmal stage, this is the classic phase when this diagnosis often becomes more obvious. So there's lots of paroxysms of coughing. Usually it's a series of kind of coughs with no inspiratory effort. Then you have a forced inspiration, which causes the whooping sound. If you've never heard it before, definitely recommend going on YouTube to find videos of infants with this cough because it's so characteristic and you won't forget it. The cough is often associated with post-tussive vomiting and can be very severe, especially at night, especially in infants. The third phase is the convalescent stage, and this is the point where the coughing gradually gets better over time. Usually this is called the cough of 100 days because it really truly does last a long time. The clinical presentation and course is typically less severe in kids who have been vaccinated and tends to be much worse in young infants. Next slide. Definitive diagnosis is made by nasal swab for PCR for Bordetella, which is then sent to public health. If you did do a CBC, you would see significant lymphocytosis, but again, not necessary for the diagnosis. Chest x-ray is usually not very helpful. There are clinical criteria for probable pertussis diagnosis if you're awaiting a swab. It's available on sort of the CDC website. This includes sort of a cough that lasts over 2 weeks plus one of the following. So coughing paroxysms, inspiratory whoop, post-tussive vomiting, or apneas. However, because we have easy access to PCR testing, we do usually wait for confirmation of the diagnosis, especially when there's a question of prophylaxis for close contact. In terms of treatment, macrolides will shorten duration of symptoms and decrease transmission, especially when you start it early in the course of the disease. The challenging thing is the typical symptoms usually don't show up until the paroxysmal stage of the disease, which is already several weeks into the disease. In peds, we typically will choose azithromycin because this is the one macrolide that can be used in all age groups. Duration of therapy will depend on which macrolide you choose. Azithromycin, it's 5 days, whereas the others are longer. So that's kind of another reason that we tend to choose azithromycin. Pertussis is a reportable disease, so close contacts may be offered prophylaxis. The post-viral cough, I just wanted to talk about quickly because this always comes up in discussion, and I think it's one of the most challenging things to deal with. It's incredibly distressing for patients and families, and fortunately something we can do very little to treat. I still think that the key is managing expectations early. Anytime I see any kid with any respiratory anything, I set expectations the moment I see them and tell families that the cough is going to last at least 4 to 6 weeks. We don't need to do any investigations unless there's worsening of symptoms or if a cough is lasting more than 6 weeks in otherwise healthy children. There's no evidence for use of SABA or steroids in these patients unless you have a history that's convincing for an alternate diagnosis like asthma. Over-the-counter cough suppressants are not recommended and are actually associated with adverse events like overdose and sedation in kids. So be cautious, especially in those younger than 6. There used to be a CPS statement on this, but I think they recently took it down, but it's still on choosing wisely. Honey is a great antitussive and has antimicrobial properties. So I usually will recommend this as a natural cough suppressant in kids who are over 1 year of age. I also recommend humidifiers, especially if you think that there may be an element of postnasal drip. Next slide. Moving on to some points about prevention and immunizations, I will preface this by saying I don't do primary care and therefore don't do vaccines in my practice, but I do have some general information from the Canadian Pediatric Society and NACI. With regards to COVID, most children will have asymptomatic or mild disease. However, there can be some long-term and serious consequences of COVID, in particular, multisystem inflammatory syndrome in children, or MISC, which can cause significant morbidity and mortality. For this reason, we're still recommending COVID vaccines for the pediatric population, especially in children over 5 years of age. For children who are younger, so the 6-month to 4-year age group, NACI recommends that those who are at high risk, so have medical complexity, they should be vaccinated. All other children may be vaccinated, and that this should be a discussion with parents with regards to local epidemiology. For example, if you have a local outbreak, risk of exposed daycare attendance, or high-risk contacts. The primary series in these kids involves 2 doses of Moderna and 3 doses of the Pfizer vaccines. Because because of this extra dose, there is a slight preference for the use of Moderna in this age group. If they're immunocompromised, that's an additional dose on top of this 2 or 3 doses. Otherwise, we don't recommend one vaccine over another in terms of Moderna versus Pfizer, as the risk for myocarditis and pericarditis are essentially very low and equivalent between the 2. I've included a link to the CPS statement that I think has been shared in the chat that has some nice clear tables about timing of vaccines in the different age groups. In kids younger than 6 months, I usually just counsel parents on cocooning and making sure that all eligible caregivers are vaccinated to protect the infant. Next slide. One thing that can be helpful when discussing COVID vaccination with families is the risk of long COVID or PASD. The incidence of this in kids is far less well characterized than in adults. Incidence varies depending on the studies you look at, but it's typically around 10 to 20% within the first 6 months post-infection. In terms of symptoms, there's a huge range of them, as you can see from this graphic I got from the AAP article published earlier this year. You can have symptoms that are from persistent COVID infection, like prolonged cough, fatigue, brain fog, etc. You can have symptoms that are in keeping with an exacerbation of an underlying condition, for example, persistent cough in kids with asthma, exacerbation of mental health and neurodevelopmental conditions, flares of chronic disease, etc. We're also seeing higher rates of post-infectious conditions, including new onset autoimmune conditions like type 1 diabetes or MISC, as I mentioned, which can be severe and sometimes life-threatening. For the most part, treatment is usually aimed at functional recovery. There's still lots of studies ongoing on this topic, as well as long COVID clinics in a lot of children's hospitals for us to better understand this phenomenon. Next slide. I know that Dr. Warshawski's given a number of excellent talks on this, but I'd just like to briefly talk about RSV prophylaxis as well, because this is really the new and upcoming thing for this year. As I'm sure you all know, RSV season is usually between October and March, although in 2022, we had a bit of an anomaly year when we were seeing RSV really throughout the whole year. It really causes a significant burden of disease. About 30% of lower respiratory tract infections are due to RSV. And so if we're able to get wide uptake of this program, I think it's totally going to change the landscape of our clinical practice this fall and winter. For years, we've had a long-standing program targeting just high-risk infants for prophylaxis with a monoclonal antibody called palivizumab or Synagis. Because it required once monthly dosing throughout the RSV season, only high-risk infants would qualify for this program. So this includes infants who are born prematurely, have underlying cardiac, respiratory, immune, or neuromuscular conditions that would increase their risk of having severe RSV. This year, we will hopefully transition to universal prophylaxis with nirsevimab or Beyfortus, which again is a monoclonal antibody that blocks the fusion protein that RSV needs to infect the body. The difference is that this is a long-acting antibody, and therefore only one dose is needed to cover for the whole of the RSV season, potentially even beyond. Beyfortus has already been available in the US and Europe, and the data is pretty amazing. It's about 80% effective in preventing medically attended RSV infections and hospitalization, and the number's even higher for PICU admission. Abrysvo is available for pregnant women between 32 to 36 weeks. However, NACI does recommend Beyfortus as a better option for a few reasons. Infants born before RSV season may not be as protected, and preterm infants who are inherently at higher risk for severe RSV are not as protected because they're born before immunity transfer. If mom has received Abrysvo, then Beyfortus is not currently recommended, except if the infant is at high risk, at which point you can give Beyfortus to the infant. My understanding is there's no additional benefit at this point to receiving both in most cases of low-risk infants. It's really important to be mindful of the language we are using to discuss this program with families. So this is my appeal to all of you. We are seeing a lot more vaccine hesitancy and refusal post-pandemic, and therefore being clear that this is in fact not a vaccine, but is an antibody medication or immune treatment or prophylaxis, whatever word you want to use, and that this technology has been in use in decades for treatment of cancer, autoimmune diseases, etc. The other thing to keep in mind, because it is passive transfer of antibodies, is that it is effective immediately, and there's not that delay that we usually see with traditional vaccines. Next slide, please. I've listed the eligibility criteria for your reference here. Essentially, it will be all babies born in 2024 for this year. So for their first RSV season, some high-risk kids will qualify for a second dose next year to cover for their second RSV season, and I've listed those here. I'll also just add that if kids have already had RSV prior to getting Beyfortus, then there's not as much benefit to receiving it as they'll have natural immunity from the infection itself. Next slide, please. In terms of side effects to counsel on, they're fairly mild and involve rash, local site reaction, and pyrexia, but as far as I'm aware, no major side effects have been reported. There are definitely still some unknowns. For example, we're not really sure of the safety and efficacy of Beyfortus beyond 24 months of age, or for us in pediatrics, in extremely premature and low birth weight infants. In terms of administration, it sounds like a lot of public health units are still working on what the rollout of Beyfortus is going to look like. Our hospital's having daily meetings with the region's public health to address this issue. So far, what we've been told is that for babies born during RSV season, they will be receiving Beyfortus as well in hospital. I know that as a pediatrician group, we're still determining what to do for really sick neonates or those who are premature in terms of timing of Beyfortus. I have also heard some discussion about potentially expanding midwifery scope in order to allow them to administer Beyfortus to babies born outside of hospital, so at birthing centers or at home, but we'll likely hear more about this in the coming weeks. So far, what we've been told is that primary care providers and possibly local public health units will be responsible for administering Beyfortus for babies who are born outside of RSV season, and this can be given together with their routine vaccinations at their well baby visits. I'm not sure what it will look like for the high-risk infants who qualify for prophylaxis in their second season. There is a well-established RSV network that existed for Synagis administration, so I wonder if a network of this kind may help to identify and potentially give Beyfortus for those who qualify in their second year. I believe that is my last slide, and I'm happy to take any questions.
Amazing, thank you. Just before we go to questions, I'm just going to advance to the next couple of slides just to show a few resources, and then we'll definitely go to Q&A. So I just wanted to highlight that there are resources from the Center for Effective Practice, as well as the Provincial Council for Maternal and Child Health on the RSV prevention program, as well as respiratory viruses and immunization. So definitely worth checking those out, and they'll be circulated after today's talk. Next slide. And then just another flag about some of the OCFP other community of practices and resources that are available, including one coming up on integrating AI and technology into family medicine, as well as the Peer Connect mentorship program if interested in getting some peer support. Next slide. And then, of course, a reminder to our attendees that you can find recent sessions. These are some of the ones that we wanted to feature there. And you can watch these online at your leisure as well, and also obtain CME credits for that too. Next slide. And then, of course, you can access the previous sessions using this particular website, and that's what the display looks like. All right, so I think we can take the slides down then, and we'll go to questions for Dr. Stoltz. All right, so the first question here is some questions about croup. So should we still use dexamethasone if the croup is really mild? And if so, is it a different type of dosing?
No, so it's still recommended even for mild croup, and it's the same dose. It's just a single dose of 0.6 milligrams per kilo.
Perfect. And do you ever have to give repeat doses?
Sometimes. So dexamethasone will last about 48 hours. And as I mentioned, croup itself, we know it's a self-limited viral illness, so it usually lasts about 3 to 7 days. The rationale for the one dose of croup is that it usually tides kids over for that peak where they have the most airway swelling. So in some cases, yes, you may have to redose after 48 hours, but I would say that's fairly uncommon.
And can older kids get croup? There was a question about, could a 7-year-old get it?
Yes, it's possible, but essentially the physiology of croup and why, as adults we don't get croup is because kids' airways are that much smaller. And so that's why it tends to happen in that younger age group. So it's not impossible for a 7-8-year-old to have croup in the right setting, or in the case of like severe viral infection. I would say if you are having a 7 or 8-year-old with croup, that there should be a moment of pause just to consider other differentials. If we're talking about an ex-prem who's been intubated, who has subglottic stenosis or whatever, that is a totally different question. And for sure they can have croup because they may be more predisposed in those cases. But I would say an otherwise healthy, fully vaccinated 7 or 8-year-old, it would be less likely, but not impossible.
Great, thank you so much. And then another question here is about dexamethasone. Is it covered by ODB? Or if it's not, are there alternatives that we can prescribe?
I'm not familiar with ODB. I believe it's covered by OHIP Plus. I've never had any issues with it.
Okay. Yeah, no, sorry, that would be a similar kind of thing. They'd have the same type of coverage. So if it's covered by OHIP Plus, you've answered the question. That's good.
The one thing to keep in mind with dexamethasone is if you make it into a liquid for the little kids, depending on their weight, it can be a really large volume. So just counseling parents on that. They would need to take it likely to a compounding pharmacy otherwise.
Great. Thank you so much. Now moving over to pertussis, can you comment on what tends to tip you over in terms of testing for pertussis? Because, kids often they can cough until they gag, and so that sometimes can be very non-specific. I know some people were saying that you can often tell just from the waiting room, and if you hear the cough, is that kind of the tipping factor? Is there something else that you use?
Yeah, go on YouTube and see if you can find some videos, because it's a very specific, like it's cough, 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 and then that like big whoop. And then it's basically so much coughing that they can't catch their breath. And they're usually quite tired from the amount of coughing that they have. And, that kind of clinical picture. Lots of kids will have a coughing fit and have emesis, which is a little bit less in keeping with pertussis. So I would definitely suggest going on the on YouTube to find a video of a kid with pertussis. I totally agree. You can probably tell from your waiting room.
Thank you. So another question here about the nasal congestion. So you talked a bit about this earlier, so just bringing that back is, do you have the specific recommendations, especially for the younger kids? Because, the steroid nasal sprays are often indicated for 2 years and up. So do you have specific recommendations around those in terms of like using saline, not using them at all? What would be your recommendation?
When we're talking about the indication for using it for like post-viral cough or postnasal drip, I don't use intranasal steroids under 2 for that reason. I have used it off-label for things like sleep apnea, sleep disordered breathing, but not otherwise. So it's really just kind of nasal saline. And really, when we're talking about nasal suctioning and nasal saline, I'm talking about young infants, usually by 9 to 12 months and older. These kids won't tolerate it. It'll be too big of an issue and just not worth the fuss of doing it.
Great. Thank you so much. Let me see here. So one more question for you, Dr. Stoltz, about the amoxicillin dosing. So is there a max dosing despite the weight for the 90 milligrams per kilograms that you just discussed for the amoxicillin? And is there any role for BID dosing for compliance? Will you ever do BID in certain situations?
In cases when we're not worried about strep pneumo, then BID dosing may be appropriate. However, because of the relative resistance of strep pneumo, that's when we want the higher dose and the TID dosing. I'll be honest, I don't know off the top of my head the maximum dosing because the max dose is different for amoxicillin for different indications. I would say for those of us in peds, we usually just look up the dose of everything every time, unless it's a resuscitation medication. It's not something that I usually trust kind of my memory to rely on. So I always just look up the dose.
Thanks for that. So I'm just going to actually read out a couple of the questions that were answered, not live, but just the ones that were very popular, just so that way those who are listening and can't see the screen, that way you can see those. So there was a question asked about, what do we know about the long-term effects of multiple bouts of COVID infection? And so Dr. Warshawski answered that and said that it's still something that we're learning about. And people who get more severe infections, we see increased risk of multiple diseases such as diabetes, coronary artery disease, and stroke. And individuals with more severe illness can also have a more pronounced inflammatory and prothrombotic response. For individuals with repeated episodes of milder illness, the picture is much less clear as to whether or not there's an increased risk of long-term outcomes. But certainly we can say that post-COVID conditions are less likely in that population, and that is likely due to the fact that there is much less of a systemic inflammatory response. So there is risk with repeated severe episodes, but whether or not it's from repeated episodes of mild illness from COVID, that's still hard to say. I don't know if either of you, Dr. Stoltz or Dr. Grossman, wanted to add to that at all in terms of the cumulative impact of COVID infections.
The only thing I'd say about COVID in adults is that none of this is really surprising. I mean, I remember 30 years ago talking to young people who had pneumonia, and I would counsel them and tell them their antibiotic was going to get rid of their infection, but they may be down for months afterwards. This post-infectious fatigue, lack of energy, no get up and go, brain fog is very common with all of these respiratory pathogens, whether it's viral or bacteria. So, I mean, we have a lot of focus on COVID, but it can occur with any of these particular pathogens. So it's not terribly surprising. Unfortunately, after all these years, we still have no clue what makes a difference for these people. It's at the end of the day, it's time. You just have to wait.
Mm-hmm. And I think that's such a good point around the framing of those expectations as well, too, because I think often what happens with prescribing, some of these things that we talked about, like inhalers for post-viral coughs and things like that, I think it becomes from this pressure that you feel that we need to fix it and that, we need to give them something. And, your patient is kind of not always understanding that these things take time. So I think it's really important, as you said, to frame those expectations and that, even once you recover from the acute illness, that the prolonged period afterwards does take some time and it can be months. So I appreciate you sharing that. All right, and then in terms of other questions here, so actually, Dr. Stoltz, I'll go back to you. So the recommendations that you give for children that present to the practice with these infections to stay at home. So how long do you typically tell them that they need to stay at home and away from school for?
Yeah, that's a really tough question to answer. Even though it seems straightforward, because a lot of the symptoms can last a really long time. And then we need to balance the risk of spreading infections with the child being out of school and the family potentially being home and off work. So usually what I say is while they're feeling unwell, they need to stay at home. If they're feeling well enough to attend childcare, then they should be able to go. However, if they're still symptomatic, they should be masking. Realistically, for most of these infections, they're most symptomatic early on in the course, or sorry, they're most infectious early on in the course of the disease anyways, even pre-symptoms. So yeah, so I usually say if you're not feeling well, stay home. If you're feeling well enough but still having symptoms, wear a mask.
Thank you so much. And then just some questions about what you were talking about with the PASC. So is PASC more common with earlier strains of COVID, or are we also seeing it with some of the newer strains of COVID?
I don't think we really know that yet. The studies in children are few and far between, and it's such a heterogeneous sort of phenomenon that I don't know that we really understand it yet. Certainly MISC, we were seeing a lot of even in the last 1 to 2 years. And again, not so much this year. So I'm not sure.
Thanks. And then this question might be for yourself, or also if Dan wants to chime in as well too, if he's still here, we can. But for kids and the new kind of products that will be eventually coming out, are you aware of like they would be recommended to get the new variant vaccine for COVID that would be coming out in the fall, or because the XBB vaccines right now, they aren't available, they've been pulled back. So just wanted to clarify that recommendation. And yeah, and Dan, if you're here, if you can comment on that.
Yeah, I'm still lurking. Sure, happy to. Yeah, I mean, if you're going to get a vaccine for your kids, it should absolutely be the newest product, right? Like we're so many generations past XBB now, with well into all the JN1 sublineages now, with KP3 being the most dominant one we see now. So the new vaccine is going to be much more effective. I think the real point to raise in the NACI recommendations is just not as strong recommendation that children should be receiving a vaccine, because we much more rarely see those severe outcomes, and these vaccines are primarily preventing severe outcomes, right? So that's the main thing about them. So they're not great like the first run through where they prevented any infection. It's preventing hospitalization, and without that significant risk, it's a little more difficult to give a strong recommendation that every kid should get these vaccines. So we still recommend them. If you're going to get the new one.
Great, thank you. And I'll close things off with one kind of fun question for you, Dr. Stoltz. So someone asked here about what is the dosing of honey for a cough? Is there an evidence-based recommendation for that?
Not that I'm aware of. I usually just say, if you're having a lot of coughing, give them a teaspoon of honey or a teaspoon of honey dissolved in warm water for them to drink, because that can just be soothing for their cough.
Awesome. Thank you so much. And again, thanks to all of our panelists here. It's nice to see you all on the screen together. So, on behalf of the planning committee as well, thank you all so much for such an amazing, engaging session today. And with that, if we can just pull up the slide deck again, we'll just show the closing slides there. Perfect. So just to confirm for our attendees, so this session was recorded, and a curated question and answer will also be posted as well. Our next community of practice session will be on October 18th, 2024. So please save the date. And please don't forget to fill out the surveys that will be emailed to you. It's really helpful for our committee to know what you liked and where we can improve. And I wish you all a wonderful Friday. Enjoy this nice warm weather and the start to the fall. And we'll see you soon. Take care.